And we are going to talk today about geropharmacology. This is part two of the geropharmacology lecture. We want to discuss multiple medication use and polypharmacy. Typically, polypharmacy is about 4 to 5 medications that an individual takes at any one given time, total, I guess, in 24 hours, not at just one sitting. And typically that happens because our older adults particularly have multiple diseases which require multiple providers. Some of those are providers like their primary care provider and then specialists. Patients also do some self-prescribing and experimentation in order to see what will work and what won't work for their condition or pain that they're having. They collect medications. Just like we saw in the seminar number 2, they will have medications that are outdated, medications that belong to someone else that they are going to use maybe someday or maybe all the time. And we also have some trouble with the patients and healthcare providers communicating well back and forth between each other. So about 20% of the community takes over 10 medications, and then about 5% of the community takes 4 or more medications. So as far as multiple diseases, we've kind of talked about some of this before too. We know that there's a significant amount of older adults who have hypertension and arthritis. Those are up and in the almost 50% range or over the 50% range. Heart disease, about 30 to 40% of people, and then about 20% of the population has diabetes. And then you can combine a lot of those, which make it even more difficult. So typically when physicians prescribe medications for older adults, we need to make sure that they have a specific reason. If we can stop one before we start a new one, it would be helpful. And definitely don't give a medication to treat a side effect of another medication. Let's change the first medication. And then the big idea, you're going to need to know this, start low and go slow. You guys already know about dangerous abbreviations. This is a link that'll take you to those dangerous abbreviations. You don't need to memorize any of them for my tests. I just want you to be aware so that you don't fall into that habit of using abbreviations. Spell it out. Take your time to do that. Use your most clear handwriting and definitely print instead of write. Then we can talk about compliance or adherence. And compliance and adherence are two words that you'll hear used alternatively, meaning the same thing basically. And adherence is the word that is more popular today, but they'll use compliance occasionally as well. So the medications are prescribed in a certain way, but the individual who's taking them may or may not take them in the way that they're prescribed. So you have to really look at how the medications are prescribed and then also how the medications are taken or not taken. That poor adherence can lead to a lot of problems. So lack of understanding, misinterpretation of directions, those sensory impairments can make it hard to read or hear directions. The drug regimen may interfere with activities of daily life or daily activities. If they have a very complicated regimen, like take this 2 hours before you eat or an hour and a half after you eat, it gets too complex. For an older adult, that complexity can be very overwhelming. And when you start adding multiple medications that have to be taken multiple times a day, it gets confusing for individuals. So we want to try to keep things simple, especially as that functional ability of the older adult is declining. We can also see that people fail to understand why a medication is important or what the goals of the medication are. They don't believe the medication will work or that it's even necessary. And then there's economic reasons, the cost of medications or not getting refills, saving, sharing meds, cutting them in half, or going on alternate days to try to make the medications last longer. Generally, a lack of support from other family members as well could also impair the ability to take medications for an older adult. So in an example of this problem, I think it was actually on a police show, but they had an individual a family that was Hispanic. The wife had come in and they sent her home with a medication, and it was a liquid medication, and it said something like take 1 ounce of medication 3 times a day. And when they read that at home, because they were Hispanic and didn't speak English as their primary language, they read ounce as 8. And so husband gave her 8 ounces 3 times a day, and she died. It's important that we make sure that individuals understand exactly what we are prescribing, how it works, and then what to do if something negative comes up. So we know that 28% of older adults who are hospitalized are actually due to adverse medication reactions, and we call these adverse drug reactions, or ADRs. About 17% of those are related to an actual pill that's caused an adverse reaction, and 11% is due to non-adherence. If you are taking 4 or more medications, you have a significant risk of experiencing at least one adverse reaction to one of those medications. It's also important that we question individuals well. We did have a gentleman who came to the emergency room to see us several years ago, and he had urinary retention. He was going to have surgery on his prostate gland in the coming week, but he couldn't void. And so, we did all the things we could think of to try to help him void before we needed to try to put a catheter in. We can try to put a catheter in, but it's probably not going to work because he has a prostate gland that is blocking the area. After we had tried to put the catheter in like 3 times, we couldn't get it in. We're going to have to call the urologist to come in and do a painful procedure so that this guy can actually go to the bathroom. And he says, you know what? I think I might have taken the wrong pill. I may have taken this other pill out of my pill box, and I think I took the wrong one out. And I should have been taking the pill that helps me go to the bathroom instead. So he went home, he took that medication, and within an hour he was able to void. But, he's in the hospital for hours. We're trying to help him. He's in excruciating discomfort. I think he probably learned the difference between his medicines. But it could have been a lot worse and a lot more unpleasant if he hadn't recalled that he was taking the wrong medication. Also, we can see that patients take unnecessary medications based on whatever their condition is. They might be the wrong drug for the patient's condition, the right drug, but the dose could be too high or too low, or, like I said before, taking a medicine for side effects of something else. We can certainly combine everything into one dose and look at that. I mean, it would be kind of ridiculous to get it all put into one pill, but there are other side effects that occur when we mix things, and so it's not always feasible to do that either. Oftentimes we'll have patients who don't take the drugs correctly, like I've mentioned. We could have interactions with 2 different medicines, with a medication and an herbal supplement, or medication and food. Or we could have a substance that's used, a medication that's used without an indication. So there's lots and lots of problems that could come up based on medications, and we want to try to help our patients sort this out. So this gentleman says to his poor grandson, who looks a little bewildered, Well, the Glasgow pill protects my heart from the side effects of the Pfizer pill that prevents the potential liver failure due to the Merck pill that minimizes the risk of stroke posed by the Novartis pill that reduces blood clots caused by the Glasgow pill. And of course, I have no idea what started all of this mess, but we don't need to have that type of a situation. So polypharmacy is incredibly complex. There are all kinds of problems that could impact polypharmacy. We have people who stop taking a medicine because now they feel good. We have all the different complex care needs of the individual, multiple doctors, multiple pharmacies. Then if we have forgetfulness or cultural beliefs that might impact medication compliance, that all adds to the whole mix. We know that about 95% of our adverse drug reactions are actually predictable, but over half require a physician or a nurse practitioner intervention. 10% require an ER visit and 11% require hospitalization. So adverse drug reactions really need to be prevented, anticipated, and dealt with as soon as possible. In addition, we can see a lot of different symptoms in older adults that are hard to pull apart to determine if it's a medication or if it's something else. So we might see some confusion and depression, delirium, insomnia. We could have Parkinson's-like symptoms, incontinence, weakness. I mean, it really goes all over the place. So we have to be able to tell if it's the drug that's doing this or if it's the baseline health condition of our resident or patient, or if it's a change in their health condition entirely. So we have to really peel that apart, and it takes a lot of detective work to do that. We have one of the residents at Tiger Place who started having some difficulties, more difficulties with confusion and delirium, and they think it might have started clear back 8 weeks ago, but they're not positive. They just really don't know for sure when it started, and that makes it difficult too. So remember that anticholinergic medications have a lot of drying effects on our system. So we know they cause a dry mouth, and they decrease our sweating, so it makes it harder to be in a hot environment. They cause our pupils to dilate a little bit. We can get blurred vision, tachycardia. They also cause urinary retention, constipation, decrease our gastric secretions, and they can decrease our ability to have a good memory and our concentration. So that's why our patients become confused. Here is a visual of anticholinergic side effects and toxic drome. So take a look at that. If it helps you with your learning style, then it'll be helpful. If not, then you can just cross it off your list. Another syndrome that happens quite often with all patients, but older adults too, is called serotonin syndrome. This is directly related to SSRIs, or serotonin reuptake inhibitors. A lot of times people think they're really safe, but we can get too much serotonin in our system, and our patients exhibit autonomic hyperactivity, mental status changes, and neuromuscular abnormalities. The deal is it can occur within minutes or hours of taking those medications, and then we also have to make sure that it is not neuroleptic malignant syndrome, and we'll talk about that in a few minutes. We need to be able to tell the difference between. So our patient with serotonin syndrome is going to be diaphoretic and agitated. They may have diarrhea and increased bowel sounds. Their blood pressure is typically hypertensive, but it can be labile, so it can go up and down irregularly. They'll be tachycardic, and they'll have hyperreflexia, tremors, and clonus in the lower extremities. Another review of some of these syndromes: they feel a little euphoric, so they're like, this is great. But they still might be a little drowsy, not coordinated or clumsy, restless. They may have some shivering, and they can have a fever with serotonin syndrome too. Some of the drugs that are linked to serotonin syndrome are included here. I wouldn't worry about memorizing this list. Definitely know the SSRIs, but know that some combinations like St. John's wort and SSRIs, cocaine, some of the other medications can also cause serotonin syndrome. Digitalis is another medication that actually has a really narrow therapeutic range, so older adults can quickly move to toxicity. That's called dig toxicity or digoxin toxicity, and it happens quickly because of that narrow therapeutic range. Our patients should, our older adults are not supposed to exceed 0.125 milligrams per day. On a rare occasion, you'll see someone up to 0.25, but you want to keep that dose as low as possible. The key things about dig toxicity is they're going to have nausea, vomiting, maybe diarrhea, but they're going to have some visual changes. So they're going to see blurry spots, maybe halos around lights or halos around people's heads. If it gets worse, they'll have palpitations and confusion. Any dose, any blood level, serum blood level over 3 is considered toxicity. So really be on the lookout. Anyone who's on digoxin, pay attention to any of those signs and symptoms and have a dig level drawn anytime they have symptoms similar. And then neuroleptic malignant syndrome, or NMS, is a side effect of antipsychotic medications. And this patient will typically have hyperthermia. It can be quite high, actually, over 40 degrees Celsius. Their extremities will be really rigid. They'll be agitated with delirium and confusion. And they will have tachycardia, tachypnea, and labile or high blood pressure. Really close to serotonin syndrome, but not quite the exact same thing. And then extrapyramidal side effects is another big class of side effects that you'll see that are pretty common. Tardive dyskinesia is one of those. It's an irreversible movement disorder, and again, due to antipsychotic medications. They'll have tongue and facial movements. Those usually start first, and then they'll start having slow twisting movements of their arms, legs, trunk, face, and eyes. Akathisia is a restlessness, fidgeting, and then they'll develop some Parkinsonian type movements, tremor, slow movements, rigidity, and that inflexible facial expression. Now, with extrapyramidal side effects, these, once they set in, they'll be permanent at some point. But if we can catch them soon enough and stop that medication and switch to another, then we can get rid of them. Beers criteria is the criteria that I've talked about before about medications that are potentially inappropriate for older adults. There are certain classifications, drugs that you should always avoid and drugs to avoid with certain diagnoses. And then you should also pay attention to the black box warnings that the FDA puts on things as well. Now remember that you have an assignment coming up about the Beers criteria. You can interview an older adult, someone over, let's say, 55 or 60. They need to have at least 4 to 5 medications. That can include over-the-counter medications. And there's also a substitute of some medications to look up if the person you interview doesn't have any medications that are on the Beers list. So check that out as well. If you need a resident or patient, you can use a friend, a family member, you can call a grandparent, you can use a patient on your med surg floor, or I can get you set up with someone at Tiger Place, so just let me know. Let's see. Also, over-the-counter medications, you want to really pay attention to these too. We have a ton of over-the-counter medications that we can administer or self-administer these days. You want to ask about them, and you're going to have to really probe and get them to tell you about their over-the-counter medications. Sometimes they won't even consider those to be a medication. It's not on their top of their list. So ask them about them. Ask them several times about them in different ways to try to get the right answer. Herbal preparations have a really important cultural importance in some cases. They're not usually or not always standard preparations. What that means is that one company may prepare it in a different way than another company, so you might not be getting the same dose, and sometimes there's all kinds of other weird stuff that are in those. They may interact with prescription or other over-the-counter medications, and they almost always lack research support for claims of efficacy, which means they don't likely work. There's no research to support that they work and do what the company says that they actually do. For drug safety in home environments, it's important to teach others to keep their drugs in the original labeled container, to not share drugs with others, to finish a prescription, don't save it for the future, read labels and ask questions. If we need to dispose of medication, sometimes there are authorized medication take-back programs, and you can take them to those. If not, then we dispose in the household garbage. So you can mix medicines with dirt, kitty litter, used coffee grounds, put the mixture in a container, throw it in the household trash, and then, scratch all information out so they can't tell, anyone can tell whose medication it might be, and then you can just dispose of those containers. Same thing with needles and sharps, although I typically tell people to wrap it up in duct tape or something as well, and then put it in the garbage. Some medications can be harmful and shouldn't be flushed. So you want to make sure that these drugs on this website don't get flushed down the sink or toilet, as they may not be safe to flush, but there are some that are fine if they're flushed, so you just need to check that out as well. When you talk to your older adults and they're coming in and being seen, it would be important to see if they've brought their medications with them. Ask for a current list. Ask how they take them, if they've started any new medications recently, and then ask about over-the-counter medications, herbs and supplements, etc. You might also want to ask your older adults about problems opening bottles, how they remember to take their medicine, what time of day, if they take it at the same time of day every day. What happens if they skip a dose? What do they do if they forget one dose? How do they make up what they've missed, or do they? And what do they do when they run out of medicine? Do they have any trouble paying for their medication? And certainly find out what questions they have themselves. So that's the end of part 2, and I will post that and part 3 here in just a moment.